Welcome to Nourish MD, Doctor Dietitian Dialogues, where doctors and dietitians empower you about your health and discuss and provide a better path to health and wellness. Proudly presented by Concierge Medical Practice Private Physicians Medical Associates, PPMA, with your hosts, registered dietitians and nutritionist, Lauren Papanos and Romana Brennan.
Hello, everyone. Welcome back to the Nourish MD podcast. I'm one of your hosts, Romana Brennan. I'm one of the dietitians at PPMA. Today, I'm joined by Dr. Fan, who is a board-certified dermatologist with UCI Health. Dr. Fan specializes in the diagnosis and treatment of both general as well as complex skin conditions such as acne, eczema, psoriasis, autoimmune skin conditions, melanoma, as well as other skin cancers. We are in for a really great conversation today about dermatology. We're going to cover a whole handful of those different specialties. So really excited to learn from Dr. Fan today. Dr. Fan earned his PhD and MD degrees at Weill Cornell Medicine in New York City, and then completed an internship at Memorial Sloan Kettering Cancer Center, where he worked with oncologists to care for cancer patients more so in the hospital setting. And Dr. Fan also completed a residency in dermatology at the UCI School of Medicine, where he also served as chief resident. So we've got a lot of accolades with Dr. Fan here today. But Dr. Fan, anything else you'd like to share with us about yourself or about your professional background before we get started?
Thank you for having me on the show. It's really great to be here this morning. I just wanted to add that, I'm from Northern California, but also lived in Southern California before. And I guess one other thing about my bio is that when I was in New York, I also did a PhD in immunology, studying, about how bacteria influence the immune system and how cells of the immune system move around the body.
Oh, how interesting. I'm sure that gives you a really great insight into some of these more skin issues and how the immune system can be so intricately involved in all of those autoimmune conditions, which I'm excited to dive into today. Among those conditions that I had rattled off earlier, what are some of the most common reasons that patients come to see you?
Yeah, so actually most of my clinics are at UC Irvine's Chow Family Comprehensive Cancer Center. So there I see patients with rashes related to cancer treatment or, skin lesions that in the setting of if they have a prior cancer diagnosis, those take on a whole different significance. I also see patients with skin cancers, and then I have a special interest in lymphomas of the skin, which is a rare condition that requires multidisciplinary collaboration between a dermatologist and an oncologist. And then, as you said before, I also do some general dermatology at the UCI Dermatology Center in Irvine as well.
Wonderful. So it sounds like most of your time is spent doing things related to skin cancers. Is that right?
Yeah, that's what most of my clinics have been right now. Yes.
Okay. Wow. How interesting. To kind of step away from that side of things to focus a little bit more on more of the general side of dermatology that you do see. Let's chat a little bit about some common causes of hair loss, acne, eczema, some of the things that, at least within our population, we see a bit more frequently, but would love to gain your insight into the common causes of those, as well as how you begin to formulate a treatment plan for some of those conditions.
Sure. So we do see those patients in, the general population as well as cancer patients. I would say the most common cause of those conditions, this is a little bit of a cop-out answer, but is multifactorial. So they have multiple causes contributing to them, and they're kind of complex conditions in that sense. In general, a lot of the conditions you mentioned have a major genetic component. For example, especially for patients with eczema, those patients often have other allergic type symptoms and diseases as well, including asthma and allergic rhinitis and seasonal allergies. Those patients often have a family history of similar conditions as well. And so that is called atopy. And so for those other conditions you mentioned as well, like acne and hair loss, also have a strong genetic component. Hair loss, the most common type of hair loss is pattern hair loss, like male pattern hair loss or female pattern hair loss. And those, as you know, run in families. In terms of how we start to think about a treatment plan, we kind of, have to assess the patient and see what treatments they've had before, how extensive their condition is. So, for example, with conditions like eczema, we look at how much of the body surface area is affected. If they have a limited body surface area affected, then it's treated very well with topical medications. If they have a very severe involvement involving a large surface of their body, then oftentimes they might need systemic medications.
Gotcha. Can you touch a little bit more on any additional testing, what those medications might look like, if there are any dietary recommendations that you might give to a patient?
So in terms of diagnosis of a lot of these conditions that you mentioned, so in dermatology, a lot of how we diagnose patients is by our physical exam. So we see them in our office, we look at their, skin, we look at any lesions and how they're distributed on the body, the size and the color and the shape of the lesions. For hair loss, we look at the pattern of hair loss, for example, whether it's diffuse on the whole scalp or does it have a classic like male or female pattern. We see if there's any scale or any redness. So we don't necessarily order a lot of tests. Sometimes we do to evaluate if we suspect there's an underlying systemic disease, but many of the things that we can diagnose just based on our physical exam, which is great. And then sometimes if it's something that's a little bit less common or a little bit confusing, we might do a skin biopsy where the pathologist can help us look at the tissue under the microscope and see if it fits with a particular type of skin disease.
Got it.
I think you asked a second question as well.
Yes, just curious in terms of treatment plan. Of course, as you mentioned, these conditions are very multifactorial. So maybe it's a couple examples as opposed to walking us through a full treatment plan. But what are some of the medications, whether those are topical, oral, or some other even potentially alternative modalities that you might recommend or include in someone's treatment plan?
Sure. So I guess let's, just to really hone in on something, we could talk a little bit more about eczema. So like I was saying before, if someone has a limited area of skin involvement, all we might need to do is treat with topical medications. So that's often topical steroids to start with. And sometimes people are, they kind of want to go to systemic medications right away, or they kind of are tired of trying topical medications and they just want a pill that they can take. And the reason that we often really like topical medications is that, you're putting the medication right on the organ that has the problem. So the great thing about dermatology is that the organ that we're treating is the most accessible organ. It's on the outside of your body. So you can put the medication right where it needs to be. And by giving you a topical medication, we are less worried about any sort of systemic side effects that could happen if you were getting an oral medication. So generally, topical steroids are what we start at first, and there are different strengths of them based on the part of your body that's affected. So we have to use a weaker topical steroid if you have eczema on the face, versus we can use a stronger one if you have eczema on the body or on the hands. If our topical steroids don't work, or you have like a much larger surface area involved, which we do see quite often, like in patients who have severe eczema. There have been really great new medications that came out in the last 10 years that are really targeted to the type of inflammation that is going on in eczema. So the one that I'm thinking about that we use most frequently is called dupilumab, or the brand name is Dupixent. You might have seen that in ads on TV. And so that's an injectable medication. And the great thing, again, is that it's really targeted at the exact molecule that causes a problem in eczema. And so in the old days, we would treat eczema by kind of broadly suppressing someone's immune system. And now we can just hone in on that part of the immune system that's causing the problem. And so when people take Dupixent, which is approved for eczema down to babies that are 6 months old, and it's super safe. But when people take that medication, we don't consider you to be immunosuppressed. It's just blocking that one part of the immune system. In terms of, an overall care plan, which you kind of asked about as well, what other things do we do besides prescribing medications? So we also think a lot about how you take care of your skin. So patients with eczema have really sensitive skin that's really easily irritated. So you want to avoid fragrances or any sort of like harsh cleansers. So we always recommend really clean, personal care products. And then we talk a lot about how you moisturize your skin, because one of the primary defects in eczema is that the skin barrier is not as good as normally. And so you should moisturize your skin very frequently. Regarding whether diet plays a role in eczema, I think it's a little bit controversial. I would say for most of our patients, diet does not play a big role in their eczema. But there are certainly patients whose eczema might flare if they, consume a certain allergen. But that's the minority of patients. I do think for a lot of our skin diseases, patients would probably benefit from eating an anti-inflammatory sort of diet, like you've talked about in your previous podcast. But things like eating more whole foods, less refined sugars and carbs, and then eating more like fruits and vegetables and fatty fishes and natural like oils like nuts and avocado and stuff like that.
Yeah. Well, thanks for talking us through that. I know it can be a little bit of a challenge when you deal with so many different conditions, and treatment plan, of course, is going to be so individualized. Quick question about some of those treatment options. Is there a certain time frame that those medications, whether it's topical steroid use or some like Dupixent, for example, is there a certain time frame that individuals should be taking those medications? Should they not take it longer than X amount of time? Okay.
So for topical steroids, we usually don't recommend using them for a very long time on the same exact spots on your skin. And what can happen is that if you use the same topical steroid on the same area of skin for a really long time, it can cause the skin to thin out, and you could get stretch marks, or you could get like little dilated blood vessels that you can see there. And that can take a long time to reverse. So we say kind of up to 2 weeks max if you're going to treat it on the same areas. In terms of what's the long-term, outlook for patients with eczema, it is a chronic condition. It is something that, actually, I would say two different things, which is one is that sometimes kids who have eczema will grow out of it. So in that sense, it might not become a chronic condition, but for adults with eczema, it often is a chronic condition, and it's a lifelong, challenge of moisturizing your skin and staying on top of it, and then using the medications that we prescribe as needed to keep symptoms under control. And then for the newer medications like Dupixent, I think because they're relatively new, we don't have that much data in terms of how long patients may need to be on them. But one approach that we do have is that once patients get on those medications and their skin becomes clear or much improved, we might talk about, spacing out the treatments so that rather than getting it every 2 weeks, you might get it every 3 weeks, then every 4 weeks, and then see how little of it you need to keep the disease under control.
Gotcha. No, that makes sense. And I think it's helpful for individuals to think about in different life stages, at what point in time are these conditions popping up? And, if this is something that you might have to manage long-term versus something that you might grow out of.
Enjoy high-quality supplements shipped right to your door with full script through Private Physicians Medical Associates, PPMA. Reap the health benefits of pharmaceutical-grade vitamins. Set up your free PPMA account today. Visit privatemds.com.
Let's shift gears a little bit and talk more about the autoimmune side of things. So this might be another kind of tricky question to have one answer to, but what might treatment look like for someone struggling with more immune system driven, more so autoimmune skin conditions, psoriasis? How would that look a little different than something like eczema?
So eczema and psoriasis are both immune mediated skin diseases. We don't quite think of them as autoimmune diseases, like in a technical sense, where when I think of an autoimmune disease like lupus or rheumatoid arthritis or scleroderma, I think of a disease where the immune system kind of is responding to a specific antigen that's a self-antigen. So basically the immune system is attacking a specific part of the body that it isn't supposed to. Whereas I don't think of eczema and psoriasis in quite the same way, that scientists haven't studied those and identified like a specific thing that the immune system has lost its tolerance for. I think of them more as inflammatory skin diseases, but certainly psoriasis is another very common skin disease that we see. One important thing about it that people should know is that psoriasis, or patients with psoriasis, can have arthritis as part of their symptoms. So something to be aware of, that, if you have psoriasis and then you notice that you're having a lot of joint pain, especially that's worse in the morning, and a lot of joint stiffness, and it takes a long time for that pain and stiffness to go away in the morning, or it gets better with activity, then you might actually have arthritis that's related to your psoriasis. And similar to eczema, for psoriasis now, we also have really great targeted medications that are directed at the specific pathways that are kind of causing the problem in psoriasis. So no longer or less often do we have to, immunosuppress people generally, where we can now just target the problem.
Got it. Thank you for making that distinction. I think that's helpful for myself and for individuals listening. So can you dive a little bit deeper in terms of what we're looking for if they are autoimmune skin conditions? Can you rattle off some of those conditions? How might those present differently or manifest differently? And then also, how might we get to that determination that it is something that's more autoimmune in nature?
For sure. So, some of the more common autoimmune skin diseases that we see, I would say lupus is probably one of the more common ones. Lupus is not just a skin disease, but sometimes people have lupus that's just limited to the skin. And sometimes that can present as, a rash on the face in a sun exposed distribution. And sometimes, patients also have other symptoms like sores in the mouth or hair loss. And then they can have kind of systemic symptoms as well. For example, joint pain, or fatigue, or problems with their kidneys. And so oftentimes those patients come to their primary care doctor first, or, they see a rheumatologist, and then dermatologists, including one of my great colleagues at UCI, Dr. Min. They really play a great role in helping take care of these patients as well. And so dermatologists are really helpful, again, in our physical exam. So we're really confident in, looking at skin rashes and lesions and seeing if it could fit with a autoimmune skin disease like lupus. And like I said before, sometimes we need to do a skin biopsy where it can show signs that are consistent with an autoimmune skin disease.
For sure. And from the standpoint of dermatology as opposed to rheumatology, I'm sure there's a lot of crossover in that level of care, right? Are these conditions something that have you seen anyone be able to successfully treat and heal from, or is the goal more so symptom or flare management?
For sure. I would say, similar to eczema and psoriasis, that these are chronic conditions. So unfortunately, we haven't gotten to the point where we could say that anyone is truly cured, I would say. But we are often successful in putting them into remission with our treatments, and then we just monitor them closely to see that the disease doesn't.
So now let's move the conversation more toward melanoma and skin cancers. Can you just walk us through what are some types of skin cancer in addition to melanoma, which I assume is what most people have heard of?
Definitely. So the most common type of skin cancer overall is called basal cell carcinoma, also known as BCC. That's actually the most common type of cancer overall. And then the next most common type of skin cancer is squamous cell carcinoma. And both basal cell carcinoma and squamous cell carcinoma kind of come from your keratinocytes, which are kind of like the main cells that make up the skin. In contrast to that, melanoma arises from melanocytes, which are the more rare cells in your skin that make the pigment that give you your skin color. And so melanoma, we generally think of it as the worst type of skin cancer to have. But for all of these types of skin cancers, if you can catch them at an early stage, which we as dermatologists help you with by screening and looking over your skin, if you can catch them at an early stage, then the prognosis is much, much better.
Yeah. And what does responsible screening look like for different skin cancers? What should people be looking for if they aren't actively seeing a dermatologist on a consistent basis to make sure that they are detecting any skin issues early on or something that might raise a red flag for them to consider seeing a dermatologist?
Yeah, that's a great question. So, right now, public health guidelines don't suggest that everybody should see a dermatologist for skin cancer screening. So, the people who should see a dermatologist for skin cancer screening would be those people who might have a family history of skin cancer, if they've had a lot of sun exposure over their lives and they have, sun damage on their skin, if they have a lot of moles, people who might have a history of radiation or immunosuppression, because the immune system actually protects you from cancer and gets rid of skin cancer. So people who are on immunosuppressive medications have a higher risk of skin cancer. Your other question about what might symptoms of skin cancer be and what are things to watch out for. So what we often say is that, if there's something on your skin that's painful or bleeding or growing, or, something that looks like a pimple or a sore, but it's just not going away, those are all things that you might want to bring to your primary care doctor's attention or see a dermatologist for.
Got it. So it sounds like a primary care physician would be a good first step, and then they can help determine if a referral to a dermatologist is necessary.
Absolutely. And actually, a lot of primary care doctors feel comfortable screening their patients for skin cancer too. So, especially if, there's a wait in seeing a dermatologist, your primary care doctor is also trained to look over your skin and, report on any concerning findings.
Okay, wonderful. Well, from a dermatologist perspective, can you share with us some of your three top tips for protecting skin health and preventing skin cancers?
Absolutely.
Do you-
Sure. So my top three tips would all have to do with the sun. So sun, sun, sun. So stay out of the sun as much as possible. And I know that's pretty hard in Southern California, but some specific things you would want to watch out for are, what the UV index is for that day and for that time of day, and you can see that in your local weather reports. So especially people who are very fair skinned or have a family history of skin cancer, you might not want to go out in the sun when the UV index is high. And that's often the case when it's during the hottest hours of the day and when the sun is at its highest. And then other than that, we recommend that people wear sunscreen regularly. And we recommend the sunscreens that you use be broad spectrum, meaning that it protects from both UVA radiation and UVB as well. So UVB is thought to contribute more to skin cancers, and UVA contributes to skin aging. Um, so those are two things. And then other things that are helpful are, if you're going to go out in the sun, in addition to wearing sunscreen, you can wear a really wide brimmed hat, sunglasses, um, and protective garments, like garments that have a UPF rating that tells you how much of the UV light it blocks out.
Do you recommend individuals wear sunscreen every day, regardless of the season and what time it is? I know we mentioned the importance of, especially when the sun is at its peak, when the UVA might be, or excuse me, when the UV index might be the highest. Are there ever exceptions?
Generally, we do. And so some things to consider with that are that even when it's cloudy out, some of the UV radiation still penetrates through the clouds. And people say, up to something like 50 to 60% of the UV on a cloudy day, and depending on how cloudy it is, can still penetrate through the clouds. So even though it's cloudy and the sun doesn't feel hot on your skin, you're still getting some UV radiation. Um, does everybody need to wear sunscreen every day? It's a little bit hard to say. I mean, I think it should be individualized for every person. Certainly, if one of your concerns is skin aging, then it would make sense to wear sunscreen every day. And for people who might have a more pigmentation in their skin that naturally protects them from the sun, we don't think they absolutely need to wear sunscreen every day from a skin cancer risk perspective.
Yeah. Do you, as a dermatologist, have any preference from a mineral based sunscreen versus a chemical sunscreen?
I think both can be good. Sometimes people, hear chemical for sunscreen and then they don't want to use that. But I think they're also very effective. So for many of my patients, the mineral sunscreens, they can leave on a white cast. And so that's not cosmetically acceptable for them. And so chemical sunscreens are still a great alternative. And then for people who have skin of color, you might consider using a tinted sunscreen. So the sunscreen has an iron oxide in it, in addition to your normal sunscreen ingredients. And then that's great because it provides a natural tint, so it doesn't stand out so much when you're putting it on your skin.
Awesome. Any other tips you'd like to share with us, whether that's related to skin cancers or caring for some other skin conditions?
So I guess one thing that not everybody knows is that you can get skin cancer on any part of your skin. So even though the skin is protected from the sun, it's still possible to get skin cancer there. And so one thing that we do as dermatologists when we see you for a skin cancer exam is that we look at all those places where it's hard for you to look. So for example, in your scalp or the back of your head or behind your ears. It's possible to get skin cancer in the mouth, in the sense that you could have melanoma in the mouth or on the genital skin or on the buttocks. So those are all areas where you might not be able to monitor yourself, but a dermatologist or your primary care doctor can help monitor those for you. One other thing I would say is that sometimes patients with skin of color think that they couldn't get skin cancer, but everybody can get skin cancer. So those people should also be mindful of their skin. And for patients with skin of color, one area where they want to be especially mindful is that they can have more aggressive melanomas that develop on the feet and the hands or the nails. And so any sort of a dark spot that's concerning looking or changing on the hands or the feet, they should also be evaluated by a dermatologist.
Yeah, thank you for sharing that. I think that's so important. And I'm glad that you included that in our conversation so everyone can be aware that, it's not just the areas of your skin that are exposed to the sun, but it can pop up everywhere. Thank you so much for your time today, Dr. Fan. For anyone listening who might not be familiar with you or your practice, but who might like to schedule a consultation or learn more about you and your practice and the locations in which you practice, where can they learn more?
Yeah, and I would like to put a plug out for our wonderful dermatologist at UCI, and we have a great group here. And so in addition to myself, we have doctors specializing in all different aspects of dermatology, from like dermatology related to women's health and dermatology related to autoimmune conditions or, specializing in hair loss. And you could really see any of us or we could find the right person for you depending on what your, main concern is with respect to your skin. And to make an appointment with any of us, you could go to ucihealth.org. Or the phone number to schedule with dermatology is 949-824-0606.
Thank you so much, Dr. Fan. And if you're currently a PPMA patient, feel free to call the office. We'd be more than happy to set up a referral to either Dr. Fan or one of his colleagues to take care of you in the context of dermatology. So thanks so much for your time, Dr. Fan. And for everyone listening, thank you for joining us. We will catch you in a couple of weeks with another episode.
Thank you for joining us for today's episode of Nourish MD, Doctor Dietitian Dialogues. This podcast is intended for general educational purposes only. It is not a substitute for professional medical advice. Please consult with your healthcare provider before beginning any nutrition or supplement recommendations. Sign up for our mailing list so you'll never miss an episode of our wellness journey. See the podcast description for the link.